Okay, so novelties. Well, you know that Sprengel deformity is not only not in Sprengel deformity, not only the bone is involved, so the scapula is high positioned and small, but there is also a periscapular soft tissue abnormalities with muscle hypoplasia and adherencies. So we will talk about endoscopically assisted Woodward procedure, about what happened with the glenohumeral joint, and also about vascular anomalies. By my local culture, let's say that we use descending techniques, the Woodward technique, to correct the Sprengel deformity. So that's why we thought about decreasing the invasiveness of the procedure in these children. So we published first this case report that I shared. So we did the same surgery using two portals. And through those portals, we detached the origin of the periscapular muscles. So our indication is less than 120 degrees of elevation. The lower portal is placed distal to the lower border of the trapezius, and the upper portal is at the level of the spine. So we do a working chamber, just tainting these soft tissues with a long Farabev. And through the distal portal, we do the release of the lower trap and the romboid. You can see here the tenting, and here how we release those muscles. And through the upper portal, we resect the upper angle of the scapula. So you release the levator scapulae, and we also release the upper trap. We don't do formal therapy. We keep the sling for a couple of weeks, and then we motivate the children and the parents to do activities that need shoulder elevation. So we analyze our first 12 children. I have shared also the feature paper with a mean age of 8 years and a follow-up less than 24 months. And we can talk about two groups, less severe deformities, which will be grade 2 or 3 Cavendish group, and then a severe deformity group, in which 3 grade 4 associated to Klippel fail deformity were treated. So we gain a mean of 50 degrees of shoulder elevation, but only 20 in the severe group, like this girl. We descend the scapula a mean of 4 centimeters. And then we check the scapulothoracic motion. I've never seen this analysis in another paper. So we check the vertical translation, scapulothoracic translation, bilaterally, pre and post-op. You can see here how we gain 4 centimeters, mean of 4 centimeters of translation. We check also the rotation of the scapula. There is a decrease of rotation of the scapula, and we gain a mean of 25 degrees of scapular rotation. And where else? And you can see here one of the severe group children. So this is the normal side, and in the involved side there is no motion at all, no translation, no rotation. And when you do the surgery, you improve this scapulothoracic motion. You get some improvement, less than in the less severe group. There. So I don't do arthroscopy. I don't do endoscopy. So currently I'm doing the same procedure, but percutaneously, using this hook electrocautery. and the results are similar. And in that way, logistically is easier for me. I don't depend on my colleague. So in grade 2 and 3 children, this technique is worthy in the sense that you get good outcomes in the scapulothoracic motion and shoulder elevation. And because the results are cosmetically really good. In severe deformities, you have moderate results, but I don't think it depends on the technique. I think that it depends on the glenohumeral joint involvement. So that's the next point. What happens with the glenohumeral joint? Because we have been said that the loss of motion, the decrease of motion, these children is because of a loss of motion in the scapulothoracic joint. But some months ago, we published our technique to clinically measure the glenohumeral motion in children with brachial plexus birth palsy. So I did the same with these children, and it's been published in this journal, and that I shared. So let's see this kid with Sprengel deformity. When we check these children, we saw that there is an statistically significant decrease of the passive internal rotation in the abduction and in the crossbody adduction. So there is an external rotation contracture that maybe it's not important clinically. But what is more important is that we also saw a statistically significant decrease in the passive glenohumeral abduction. So we take as a reference the spine and the humerus. And this was, it correlated with the degree of the deformity, with the Cavendish degree. And if you see this patient, what was in the severe group, combining Sprengel and Klippel fail, if you look at the CT scan, you see a passive glenohumeral abduction angle of 40 degrees. If you check the other side, this angle is minus 30. So there is 70 degrees of difference. And if you look to the patient clinically, the same. Passive glenohumeral abduction of about 40 degrees in the non-involved side, while in the other side is minus 30. So those not really good results that we were obtaining when operating these children is not only explained by the technique we are using, but because the glenohumeral joint is also involved. There is a contraction. The other question is if we can do something about this glenohumeral contracture. Anyway, so let's move to the vascular anomalies. So we published some years ago this case. It was a child with a Sprengel, again with a Klippel fail. So the radiologist did a angio-MRI, and he saw that the subclavian artery arose from the vertebral artery. So in that situation, we decided not to descend the scapula because we were afraid of a vascular accident. So we did a mere procedure. But we started to study these patients. And in 18 consecutive Sprengel deformities, we did an angio-CT or an angio-MRI. And we found 3 of these subclavian arteries originating from the vertebral artery. All of them were in the context of a Klippel fail. So in 6 Klippel fail children with Sprengel deformity, in 6, 3 had this vascular anomaly. So it means that when you have this combination of malformations, you have to do a vascular study. And again, the subclavian artery originating from the vertebral artery. So the conclusion is that minimally invasive vulvar procedure is feasible, The glenohumeral joint is also involved, but probably only has is significant clinically regarding the adduction contracture in very severe cases. And finally, that if you have a clipal phelan and a Sprengel deformity, you have to do a vascular study. Thank you. Happy first PULM Talks for birthday. So, and now Dr. Mostafa Mahmood will moderate the talk.
Thank you, Soldado, for this excellent presentation, sharing these novelties in the management of Sprengel's deformity. And I like the idea of endoscopic releasing the muscles to free the scapula. And one of the questions in the chat room is, do you reattach the separated muscle, the trapezius and the rhomboids again in a lower position, or you just depend on freeing the scapula from its place?
We don't reattach the muscles. We don't suture the scapula. We just rely on the gravity.
And how do you think reattaching the trapezius or the muscles have any effect on rotating the scapula, the lateral end of the glenoid? And also, what's the long-term follow-up for this procedure? And do you have any recurrence depending on just leaving it free?
No, from my experience, I would say that reattaching the muscles or suturing the scapula is not necessary because we had really excellent results. I don't know if maybe in that severe group in which we get worse results, maybe, but I think that those worse results are related to the glenohumeral joint more than the scapulothoracic joint. That's what I think.
And what do you think the main reason for the good results is? The selection of a mild to moderate cases, avoiding severe cases, or disinserting the upper trapezius? And regarding the cutting the upper trapezius, how do you protect the spinal accessory nerve?
So I didn't say, but through the upper portal, first we check the we dissect the spinal accessory nerve. Sorry, I forgot to tell that.
Okay.
So we identify the nerve, we protect it, and we cut the muscle from the upper portal. Also from the upper portal, if there is a omovertebral bone, we prolong the incision a little bit and we take out the bone. So the thing is releasing those adherences between the scapula and the thorax, and release the muscles to put the scapula down. But I really don't think that you need to reattach the muscles.
Okay. Do you routinely remove the superior medial angle of the scapula? And do you have any anomaly related to a curved medial border of the scapula that prevents its descent?
So we systematically resect the upper angle with two purposes. One of them is releasing the levator scapulae, and the other one is cosmetic reason. So in fact, those severe patients were happy with the surgery, even if they didn't get much elevation, because the bump improved. Cosmetically, they improved because we took out this prominence. And what else? I'm not sure about this hooked I I don't I never could assess how much is the upper border of the scapula and the upper angle, how much is curved. But there is something, but I never evaluated this.
And do you routinely osteotomize or morselize the clavicle in your surgeries, or you don't need it?
This is another good question. In none of my patients, I did a clavicular osteotomy. But then when you read the, when I read the literature, the risk in older patients is high. So maybe I didn't have any problem. And I thought that maybe it was because I didn't attach I didn't force the downloading the scapula, and I didn't suture the scapula to the ribs. I don't know, or maybe I was lucky. But I think that in older patients, if you consider the literature, you have to osteotomize the clavicle. I agree with that.
Have you ever tried the Mayer's procedure in Cavendish type 2 or maximally 3 for a patient with limited abduction, less than 90 or 100 degrees shoulder motion?
I've done the Mears procedure only in those patients that I couldn't do the descending technique. So it means four patients, and they improved. But I don't understand why they improved, but they improved. But the rationale, to me, the rationale is, I don't comprehend the rationale of that, but it worked. See.
Okay. So you recommend it only in cases with severe deformity that you cannot get it down, or with suspected vascular abnormality, as you mentioned, and in patients with fear of having brachioplexus affection later on. Am I right?
Well, as I said, this is like a cultural or a school thing. So in my center, they always did the Sprengel procedure. So I learned the Sprengel procedure, but I cannot say that the Sprengel or Greens or the vertical osteotomy of the Mears is worse or better than the other one. I cannot say that it's better. I cannot say that Budwar is better than other procedures. I have no experience. On the other side, Sprengel is very uncommon. And I got a lot of patients in a very short period of time because I described this technique. Otherwise, I would have seen 4 or 5 only.
Okay. And do you need 3D CT in every patient?
No. I don't think so. I think that clinically, I think it's enough. But we do the CT or angio CT or angio MRI during this study, evaluating the angiographic to do a study regarding the vascular anomalies. No, I really think it's not obligatory.
In your cases with endoscopic release of the trapezius, did you measure how much correction happened to the lateral end of the clavicle or the glenoid inclination?
No, we measure how the scapular rotation changed and the vertical translation, but we didn't measure this the orientation of the glenoid. We didn't do.
Okay. One final question: if you have rib hypoplasia of the ribs, do you still recommend the endoscopic release, or you'd better open and see, fearing of injury to anything to the thoracic wall?
Some of the patients had rib abnormalities, so we did the same procedure in the same way. Dr. Mahmood, you've tried the endoscopic release, right, or not?
We don't do it endoscopic. We do it a minimal invasive something similar to what you finally are doing, but not using a radiofrequency ablator. We just open small incision over the spine of the scapula, releasing the superior medial border and the levator scapulae. And then we open a vertical incision related to the lower border, freeing the lower part of and the middle part of the trapezius to reinsert it at a distal place. Okay. Because we believe that reinserting the trapezius as the classic woodwards will help in rotating the lateral end of the clavicle upwards, and it helps us get a better abduction.
Okay, and how are your results?
We didn't publish our results, but it's almost similar to what you achieve around 70, 90 degrees of increase of abduction in Cavendish type 2 and 3, but in type 4, only 20, 30 degrees of abduction is achieved as your results.
So our results, so we do almost the same. So our results are reproducible. Yeah, perfect.
Yes.
And okay, before finishing, I would like to present yourself because my brain now is in a mess, and I didn't want to please the hospital where you work and what you do. It's see. Most people know you, but some other people don't know you. So please present yourself. Introduce yourself. Introduce yourself. Sorry.
My name is Mostafa Mahmood. I'm a professor of orthopedics and hand surgery in Cairo University, Egypt. I'm specialized in pediatric upper limb in Abu Rish Hospital. The head of the department is Professor Hisham Abdel Ghani. We have a group of pediatric upper limb surgeons working there. We have almost around 50 upper limb surgery per week and per month. I'm sorry, and we are happy to host the next thesis meeting. God willing.
Perfecto. And Dr. Praveen, I didn't introduce you also properly. Please tell people where you work, what is your group. Most of us know your group, etc., but some other don't do. Please, Dr. Praveen.
Yeah, sure. So I am Praveen Bharadwaj. Very difficult to pronounce Bharadwaj sometimes. So Praveen is okay. I work in Coimbatore. I think you by mistake told Pune. I know you have many friends in Pune. So I am from Coimbatore. Coimbatore is in the southern part of India. And I work in a hospital, Ganga Hospital. It is a big multi-speciality, single specialty hospital. So it is only an orthopedic and plastic surgery hospital with 650 beds. So we are a nice tertiary care center for trauma, and our unit is quite famous in microsurgery. And we also have a good amount of caseload for brachial plexus injuries, both in adults and birth. And my main interest is upper limb, brachial plexus, and microsurgery.
And hemiplegia, right?
Yeah.
And hemiplegia. Okay. So thank you, everybody. If there are no more questions, thank you very much.
Thank you.
And
happy anniversary.
Second Sunday. Thank you very much. I'm happy to be between giants. Thank you.
Bye bye.